Hello, everyone. This is Hallie Stephen-Castro, and this is the presentation on care of the client with HIV and AIDS. In 1981, there were cases of a rare pneumonia and as well as Kaposi sarcoma occurring in otherwise healthy young gay men. They did coin a new term for this called the acquired immune deficiency syndrome. In 1983, they were able to identify an antibody that was associated with this syndrome. In 1984, they were able to isolate it. AIDS is caused by HIV-1. HIV-1 is responsible for 95% of all HIV infections. It destroys the body's ability to fight infection. It can be found in all body fluids, and transmission is usually sexual contact or by infected blood via needle sharing. The HIV virus infects the cells that have that CD4 antigen, and then it embeds itself into the cells, into the viral DNA. It can remain inactive for years. There's no signs or symptoms, but it is affecting the immune system. The antibodies are detectable, though, anywhere from 6 weeks to 6 months after infection. Here's a review of the life cycle of HIV. It also breaks down where some of the antiviral medications, how it affects the virus and where it affects the virus to help reduce viral replication. The HIV virus embeds itself into the T cells, and they basically become an HIV vector and create new viruses. Eventually, those CD4 cells or those T cells will start to fall. The numbers will start to fall. As that happens, the viral load will start to rise. This will weaken the immune system. The CDC has changed the way they clinically categorize HIV infections over the years. The most recent updates now has 5 stages, stage 0, 1, 2, 3, and unknown. What I want you to take away from this is that stage 3, that's where that CD4 count drops less than 200 or they have AIDS-defining illness. The progression of HIV can take anywhere from a few months to several years. There's a lot of variables that can come into play that will affect the progression of this disease. HIV is transmitted through 3 primary ways. It's going to be sexual contact, parenterally, like IV drug use, or prenatally from mother to baby. HIV is not transmitted casually by sharing household utensils or by vector. The CDC has come out with some guidelines called the ABCs of safer sex, and that's going to include A for abstinence, which may not work for everyone. B, be faithful, so in a healthy monogamous relationship. Or C, of condom use. There are also 2 categories of prophylaxis. There's pre-exposure prophylaxis for those who are in high-risk populations and that have high-risk behaviors, and those that have post-exposure, post-prophylaxis, such as an occupational exposure or a non-occupational exposure, such as a sexual assault. To reduce the risk of parenteral transmission, there is a lot of information out there on how to get clean needles or needle exchange programs, or even clean their IV drug paraphernalia. There is some information listed in your book regarding this. The HIV virus does cross that placental barrier during pregnancy, and there's also risk for the infant to be exposed during birth due to the blood and vaginal secretions during the birthing process. The HIV virus is also detected in breast milk. There are medications that can help reduce this transmission. Healthcare workers, by way of occupation, may be at risk for transmission of bloodborne pathogens due to needle stick injuries or exposure of non-intact skin or mucous membranes to blood. There is the post-exposure prophylaxis that can be available if this starts to happen, but standard precautions is the best prevention. The assessment or the noticing part of the clinical judgment model will always start with a history and include that physical assessment. Need to also inspect for any type of opportunistic infections or malignancies that may accompany immunity issues as the CD4 count starts to fall. Well, there are several opportunistic infections that can cause mental status changes. The AIDS dementia complex is caused by the HIV virus itself. There's also the AIDS wasting syndrome, skin changes, and potential kidney problems. There are numerous tests for HIV or clients with AIDS, including the ELISA test and the Western blot test. That's for confirmation testing of the virus. The antibody test to see if the body's creating antibodies to the virus. Viral load testing to see how much virus is in the blood, as well as some others. Here are some priority problems that are identified by your book. Obviously, potential for infection, especially as that CD4 count starts to fall. Inadequate gas exchange, and that being related to the PCP pneumonia, which is common in AIDS clients. Pain due to neuropathies, inadequate nutrition, so on and so forth. The amount of medications for HIV, the antiretrovirals, can be a little overwhelming. I did narrow down a list, and that's on the guided reading. I strongly encourage you to please look at that and review that. But just understand that the goal of antiretroviral therapy is to keep that viral load low and the immune system healthy. Remember, your priority problems are going to revolve around the most common opportunistic infections that affect clients with HIV who have developed into that AIDS category. PCP pneumonia is one of the primary opportunistic infections for clients with AIDS. Clients with HIV and AIDS have a very difficult time managing their pain. They tend to have a lot of pain due to neuropathy, the myelopathy, cancer, or other infections due to those opportunistic infections. Clients with AIDS often suffer from inadequate nutrition because they have increased metabolic needs due to all their nausea. They may have vomiting and diarrhea and other issues, lack of appetite due to a lot of those opportunistic infections. The client with HIV and AIDS has high risk for issues with their skin integrity or tissue integrity. Part of the problem is that they have extensive diarrhea with some of the opportunistic infections, as well as the potential for having Kaposi sarcoma, which is the purplish lesions. The client with HIV and AIDS, again, is going to be at risk for having issues with their cognition, in part due to some of the opportunistic infections can cause mental status changes and confusion, as well as the AIDS dementia complex, which is due to the HIV virus itself. Nursing actions should revolve around keeping them safe. And although there's been a lot of progress made with HIV, including life expectancy, this is really treated more as a chronic disease now, there's still a significant stigma attached to the HIV and AIDS diagnosis, and it can cause a lot of psychosocial distress. The client with HIV and AIDS is not hospitalized as frequently as they used to be. Most of them are able to effectively manage at home, so they do need a lot of teaching and education regarding home care management, self-management education, and psychosocial preparation regarding their disease process, and giving them any resources that they need. Our overall goal with clients with HIV and AIDS is to promote a healthy lifestyle, maintain that highest possible level of function for as long as possible, and reduce those opportunistic infections, and have a high quality of life and proceed with dignity throughout the course of their illness. So here is a great question. It's a 30-year-old man with HIV admitted to the acute care unit. Which assessment findings does the nurse recognize that may indicate that the client currently has AIDS? And so it's select all that apply. I'm going to encourage you to look at your AIDS defining conditions and see what applies here on this list. The patient is very weak. During his submission, he has experienced anorexia, painful swallowing, severe diarrhea, and occasional vomiting. Frequent mouth care is being delegated to the unlicensed assisted personnel. What instruction should you give this UAP? After 8 days, the patient's being discharged home, where he lives with his mother and his father. The nurse is completing the discharge instructions for him and his family. What infection control teaching should the nurse provide to this patient and family? As the nurse is talking to the patient comments that he does not know why he must live with such a horrible disease and states he knows he will die soon. What is the appropriate nursing response? True or false? Genetic testing has no benefit in the treatment plan of a patient with HIV. A patient is fearful that he has been infected with HIV. The nurse recognizes which as the first symptom associated with possible HIV infection. A. Lymphocytopenia. B. Opportunistic infection. C. Fever, night sweats, and muscle aches. D. Reduced numbers of CD4 T cells. We do need to discuss a little bit more in detail some of the clinical manifestations that can be seen with some of the opportunistic infections as a client advances into the stage of AIDS. Some of the clinical manifestations that can cause central nervous system manifestations includes the AIDS dementia complex, which again is caused by the HIV virus itself, not those opportunistic infections. But there are opportunistic infections that do cause CNS manifestations, such as toxoplasmosis and Hodgkin's lymphoma. Those central nervous system manifestations may include the headache, the altered mental status, change in level of consciousness, neurological deficits, and again, they may be related to those toxoplasmosis, the non-Hodgkin's lymphoma, as well as the cryptococcal meningitis. Cytomegalovirus is a very common virus that about half of the adults have. The problem is when you have someone who has AIDS that is immunocompromised, it can affect them much more severely. It can cause CNS manifestations, peripheral nervous system manifestations, as well as retinopathy and other systemic issues. The pneumocystis jirovecii is the most common manifestation of AIDS. It is a fungal pneumonia. This fungus is pretty common, but it affects clients with AIDS severely. The risk is predictable by that CD4 count. If it drops lower than 200, it puts them at extreme risk for developing this pneumonia. Other common opportunistic infections include tuberculosis. Again, a normal healthy adult can frequently fight off the exposure to tuberculosis, whereas a client with AIDS cannot due to the immunocompromisation. They also suffer from candidiasis throughout various areas of their body. Mycobacterium avium complex is typically found in food, water, and soil, and it usually happens late in the AIDS disease process. This is the one that's responsible for that wasting syndrome or the increased extensive amount of weight loss in AIDS clients. And consider any other infection is going to have an advanced course when a client with AIDS. Here are some photos of Kaposi sarcoma. It is a skin cancer caused by the herpes virus. It's transmitted mainly through sexual contact, but again, it's one of those common opportunistic infections that happens in the late stage or that stage of AIDS with clients with HIV. Other secondary cancers that happen in clients with AIDS are lymphomas, particularly non-Hodgkin's lymphoma. It is 5 times more frequent in clients with HIV and AIDS. The central nervous system or the brain is usually the site. Also, cervical cancer has a very aggressive course in clients with AIDS. The incidence of infants with HIV has decreased in the United States, but it is still prevalent globally. They typically are asymptomatic at birth. They may have a few signs and symptoms within a few days, but the interval from infection to onset of symptoms is much shorter than adults. Additionally, infants who are born with HIV have a much higher mortality rate than their non-infected counterparts. They do have some issues with some opportunistic diseases, but a significant problem with premature birth. Children affected with HIV also have a very short duration of course of disease. Their time from onset to being immunocompromised is much shorter and typically within about 2 years of infection. Children with HIV tend to develop encephalopathy. And again, it's just because they have a faster course of disease, and that virus tends to affect their brain a little faster than they would with their adult counterparts. So this concludes the presentation on HIV. If you have any questions, don't hesitate to reach out to me. I encourage you to explore the CDC's website regarding HIV, as well as the materials they have for prevention of transmission, such as condoms, dental dams, and female condoms.